One of the things that I hear most from patients that I see is that this is the only thing that takes the anxiety away. This is the only thing that, I'm hyper vigilant all the time. I have nightmares, I have intrusive thoughts, and this is the only thing that kind of calms that down. What the research shows us is, yes, that may be true while you're intoxicated, but over time, chronic use only worsens the anxiety. There's a stigma to seeking mental health help. I may be overgeneralizing, but I think in some of these high-pressure jobs, you're not supposed to need mental health support. You're supposed to be able to just do this job. And so where do we leave people? So then they can't talk about needing help. Smoking pot might seem like a less stigmatized type of care than saying, hey, I'm going to go see a psychiatrist.
Today's episode of Minds on the Frontline presents an educational and evidence-based examination of cannabis. As cannabis use becomes more common and socially accepted throughout our communities, frontline workers, clinicians, and leaders must understand the science behind it. Whether for clinical insight, peer support, or personal awareness, the goal is to separate fact from assumption. This is not a conversation about promoting use. It's about increasing knowledge. To better understand today's topic, we sit down with Dr. Leslie Lundahl, a clinical psychologist and behavioral pharmacologist at Wayne State University. For over 20 years, she has studied the effects of substances such as alcohol, nicotine, cocaine, methamphetamine, MDMA, morphine, and opioids, with most of her career focused on cannabis. During this episode, Dr. Lundahl helps us explore the current state of cannabis research, including its risks, potential therapeutic uses, and why understanding its impact is so important, especially in professions where use remains prohibited, but exposure is increasingly common. Minds on the Frontline is presented by the Frontline Strong Together 5 program, offering 24/7 mental health and crisis support for Michigan's first responders and their families. For more information on FST5, including free access to resources and how to connect, please check out the episode description and follow us on social media. Thank you and enjoy the show.
Good morning.
Good morning.
How are you?
I'm well. How are you?
Very well. Thank you for joining us in the Minds on the Frontline podcast, Doc.
Thanks for having me.
Why don't you introduce yourself? Tell everybody who you are, what you do, where you do it.
Okay. My name's Leslie Lundahl. I'm a professor in the Department of Psychiatry and Behavioral Neurosciences at the Wayne State University School of Medicine. I've been here for 24 years. Mostly what I do is drug research. I'm a behavioral pharmacologist and a clinical psychologist. So mostly I do research with participants in a laboratory where I administer various drugs and see what it does to their brains and behavior.
Wow.
Yeah, it's pretty cool.
That is pretty cool.
Yeah, so I've studied alcohol, nicotine, cocaine, methamphetamine, MDMA, morphine, opioids.
What's the saddest one to study?
The saddest one to study?
Which one brings the hardest to watch?
Actually, I don't really think any of them are sad. One of the things I've noticed is that people are so resilient. And so when I meet them and I think, oh my gosh, like you have lost your family, you've lost your home, you are, dependent on heroin, like you are really struggling. And yet they come in and they don't meet criteria for depression. They don't feel badly for themselves. Like they are working hard to get better. And then they say, now that I'm sober, I can talk to my little brother. My family will talk to me again. So they're very heartwarming stories. So I don't necessarily see a lot of it as sad.
That's better.
Yeah, I guess the saddest might be, we have pregnant women that come in for treatment and seeing them struggle and really wanting to work hard for this baby that they're carrying. And this is such a great opportunity. This is the perfect time for them to stop using because they're very motivated. So even that I think could be sad, but again, they're so inspiring. So
it's good to hear that from your perspective of somebody who studies these types of addictions and treatments to relieve people of that you're like, no, people are pretty damn resilient.
They
and
are.
As long as they're willing to get better, they can get better.
They can get better, absolutely.
That's great.
Yeah.
So 24 years studying this stuff. Mm-hmm. Is this what you've done your whole career or anything before that?
This is pretty much what I've done my whole career. In graduate school, I studied alcohol more, and that was mostly because in an undergrad.
Because of all your expertise in your undergrad?
Yeah, also just because.
Just kidding.
I had other expertise in my undergrad.
Didn't we all?
Yeah. I think it was just easier. You can't study drugs of abuse, like actual substances other than alcohol, unless you're in a medical school setting. So I was studying alcohol in graduate school. And then I would say my favorite drug to study is cannabis. So that's pretty much what I have focused on over the last at least 20 years.
So let's get right into that because you're here to talk about cannabis. But before we do, what inspired you to concentrate on cannabis? What makes it so interesting to you?
Maybe TMI. I had a pretty wild adolescence, and I've always been told, study what you know. So that was one thing. I
think Warren Buffett said that.
Yeah, probably. I wish I was as rich. What I noticed in high school, which maybe a lot of us noticed, is that there were some of us that partied a lot, and then at some point went on to college, graduate school, trade school, military, whatever. We sort of grew up and kind of went on with our lives. And then there was a group of us that overdosed or were in treatment or did not sort of move on. And that fascinated me. And this was back, I'll date myself, but I was in high school in the late 70s, early 80s. And this was a little bit before it was very mainstream knowledge that addiction is a brain disease, right? Or that there's a genetic component that's very heavily factored in. And so for me, it was just so interesting that why would people who go to the same high school, grew up in the same neighborhood, had known each other forever, pretty similar SES, similar family backgrounds, why did some people just sort of move on like this was just a period of experimentation? It was fun, but now I, need to move on.
Right.
And others couldn't.
Right.
And I just thought that was fascinating. So that was part of the attraction there. And then as I started studying cannabis, what's interesting about cannabis is that it affects so many different parts of the brain. If you think about something like stimulants, there's some hyperarousal, there's cardiovascular reactivity. Cannabis binds to CB1 receptors in the brain. They're all throughout the brain. So you have, music sounds better, food tastes better, your friends are funnier. You also have some balance issues. You can't remember complex things. So if somebody says to you, hey, can you go to the fridge, get me this water and let the dog out while you go? And if you're high, you're like, okay, something about the fridge. There's a dog.
Well, that was a lot.
That was a lot.
About weed. That was a lot you just
Actually,
asked.
One of my teenagers, when I say, you need to mow the lawn, pick up the scrappings, put the lawnmower away, something's going to get missed there. So
you
it's,
write that down.
I guess it's complex stuff. And he's not even high, as far as I know. And so I think that was just fascinating to me, that you could smoke something and all of these things that would just sort of happen. And so that's why I'm very attracted to studying cannabis. I just think it's a really fascinating compound.
Well, it takes a lot of interest to be good at something too. So I'm glad people studying it have such a high interest in it. You're not just some Poindexter person going, well, let's see what this devil's lettuce does. Like you're like literal, like, no, let's break this down. So,
right.
But you did say smoke it.
Yeah.
But these days,
yes.
It seems that there's 50 different ways you can put cannabis in your body or
Absolutely.
on your body. Mm-hmm. So how would you assess the current state of cannabis use in the U.S. and what is everybody using?
Well, actually, this is a pretty interesting time, I think, in the cannabis field. So one of the things I would say is that there's been a huge increase in use over time. And interestingly, it's in populations that we wouldn't normally think about. So we would always think, okay, if you are 16 to 25 or 18 to 25, certainly you're smoking a lot. But really, it's across the board. It's adults 26 to 64. This is the biggest group that's using. Daily use has nearly doubled over the last 10 years or so. So people are using a lot more. One thing I think is really interesting, the fastest growing population of new initiates, so these aren't people that smoked before, these are new people, are over the age of 65.
I'm not surprised.
Really?
I'm not.
I was very surprised by that.
No, only because
I don't know why,
people 65 is not your 65 it used to be.
That's true.
Number one. Number two, I feel like enough people have talked about using cannabis products and they haven't overdosed. So there's a lot less reluctancy to dabble in new things that aren't opiates.
Yes, right.
And when you hit 65, I think a lot of people, they start to chill out a little bit when they kind of decrease the responsibilities. I'm like, let's try this. So
that makes sense.
It feels that way. Plus, I work in a community with older people, and once in a while, you'll get somebody over 65 who either tries gummies or took too many of them, as they normally do. And next thing you know, we're prescribing Pink Floyd and some other stuff to really get them through the night.
Early Pink Floyd or After the Wall?
Whatever. It depends on the person.
Okay. Well, I mean, you've hit the nail on the head. So one of the things is that use is at an all-time high, but more importantly, or as importantly, social acceptance is at an all-time high, right? Yeah. So it used to be that there were always people that thought, well, this is harmful.
Sure.
Right? Those people aren't saying that.
Well, the
anymore.
people that heard that grew up and are now 65.
Them are now thinking, hey, yeah.
Yeah.
No, I
seems
agree.
Like.
Yeah, I agree. A friend of mine who's a physician told me when I retire at 65, that's when I'm trying it because I don't have to worry about losing my license or doing something stupid.
You hear that from cops and chiefs all the time.
Really? Okay.
I mean, in a funny way. It's more of a comment of I can't wait to be retired and just do stuff without anybody giving me a rule.
Yeah.
Well, it's what it feels like when they're saying it.
I think that's true. He also had said, I want to come do it in your lab because I know you have all this equipment to keep me safe. So he still has this idea that, you know, he could smoke it and have a heart attack. And
what
so
was the propaganda movie?
With the piano.
The guy jumped out the window?
Yes. Oh,
Reefer Madness.
Reefer Madness, yes. I just remember the guy playing the piano as if he was, you know, on methamphetamine out of his mind, but that's not what pot does.
Sure.
Yeah.
Yeah. No, I think coffee would have a better chance of doing that.
Yes.
So, again, not just smoking it. Walk us through all these different forms that are out there now.
Oh, sure. So one of the big changes I would say over the last couple decades is we have a proliferation of cannabis products. Right. So one of the things is, you know, flower we still have. It's the most common form of use. And, you know, there are still some old school people who are using bongs and smoking joints.
And you say
and
flower, which is a very new school
plant.
term from what I understand.
Really?
But like for people listening,
yeah,
weed.
it's weed. It's pot.
Yeah, it's just the weed.
Or as my dad would have said in Mary Jane,
right? Or the pot.
Or the pot.
Right.
Grass.
Right,
Yeah,
right,
exactly. And so most people are still smoking that. However, you know, as I like to say, when parents bring their teenagers in to see me, so I do a private practice. I work mostly with teenagers and young adults who have addiction issues or depression or anxiety. And parents come in all the time and say, you know, what's the big deal? He got caught with some pot at school. You know, I used to smoke pot. I turned out fine. And you have to say, well, okay, this isn't your pot. Like back in the 80s and 90s, you might have had 3%, if you're lucky, 4% THC that you got off the street and rolled a joint with. You know, pot now is at least 20, 25% THC. Some dispensaries claim 30. Most growers I know think you can't get to 30 yet, but maybe they have.
We're still talking
now.
a magnitude of nearly 10.
It's huge. Yeah, this is not the same pot, right? This is not you know, listening to Pink Floyd and sort of relaxing. This is you being stoned and not being able to move because you can't remember anything, right? So it's a completely different sort of experience. It's a different thing. And then, of course, we have high-potency concentrates, which are just sort of off the charts. These can be 90% THC, 95% THC. Your audience would probably know what concentrates are, or do you want me to?
Yeah, if you could give them a little overview. From what I understand, a lot of concentration in the form of stuff called wax. Mm-hmm. There's oils in cartridges.
Yep.
Give them a little bit of overview of what's
Sure.
available.
Yeah. So probably the most common examples would be stuff that you would dab. So dabbing is when you use a dab rig, and basically you're heating a very tiny piece of material, which is called a dab, basically the size of a nail head, if you can imagine something that small. Most of this is solvent based, so you use a solvent like butane or ethanol, and you sort of leach out the THC, and you get terpenes along with it. Actually, you get all the cannabinoids with it, and it's a highly concentrated, stripped away, you know, THC, terpene, CBD. Depending on the process, you heat it up, and if you agitate it, it becomes one form, which is waxy. If you don't agitate it and just let it cool, it becomes shatter or glass. And so they're very different looking, but they're basically the same thing. So you can dab those, you can smoke those, you can actually use an oil pen with cartridges, and that's sort of a liquid form THC.
It vaporizes it.
It vaporizes it, basically, right? So it's heated, it's not combusted. So you inhale sort of the vapor that comes from heating the substance.
So instead of a burning plant,
right,
which has its own issues, let's say,
right.
It's a hyper concentrate. Well, although I'm not having the product of combustion, now I'm inhaling very, very 100x potency here.
Right. It can be up to 95% THC. The latest stats I read, I believe the average is around 65%, but you can
still incredibly
get higher.
high.
Oh, it's incredibly high compared to 3%. Absolutely.
And now that's just inhaling it.
That's inhaling it.
Now, from what I understand, when you eat marijuana, it turns into this whole other thing inside of you as it converts, and then the experience can be different.
Very different, right? Part of it is just because of the route of administration. When you inhale something, it goes right to the brain. So you will have the effects within 2 minutes, right? You'll know that you've smoked something. With an edible, and again, these are typically gummies or chocolate or cookies. There's beverages now like LaCroix and High Noonish kinds of beverages with THC added to them. You know, part of the issue here with danger is that these are marketed like candy. And so younger kids are often very attracted to these and get a hold of them. And that's why we suddenly have calls to poison control or visits to the emergency room. But because the effects take longer to kick in, it can be 2 to 3 hours before you start to feel it. When you're intoxicated or high, you stay that way for hours. It can be 6 to 8 hours on an oral administration. Part of the problem here as well is that if you're new to it, you'll take one, you'll wait an hour or two and think, okay, I got a dud, or this isn't doing anything for me, and then you start eating more, and then you become uncomfortably high, and then these are the folks that end up in the emergency room.
And yeah, those are the people I've been called to in a number of times. And it's hard to tell somebody in that situation, oh, you're fine.
You're fine.
Because,
Yeah.
you know, I don't ever want to tell somebody who called 911 you're fine unless I can, like.
Unless you know they're fine.
Yeah,
Right,
and you
right.
just took a bunch of stuff where, like, you think the walls are closing in on you. Although I know it's really something you feel like you're experiencing now, I feel like you're going to be okay. So a lot of times you're talking them down or taking them to the hospital, and they really, really, really just want to feel okay going to the hospital. And when they're
for
there,
sure.
I'm sure they're getting some level of
Supportive care.
Yeah, very
There's not really
palliative.
anything. Yeah, there's no way to leach it out, to leach the THC out, or to
Right.
reverse it. There's no.
Yeah, the good news is
there's no
it's going to be
antidote.
over.
It
The
will
bad
be
news
over.
is it might be 6 to 8 hours.
It might be a while. Right. It might be a while.
Okay, so the
Yeah.
big trends here is a big explosion in the amount of human beings using cannabis.
Right.
The spectrum of the types of people using cannabis. I think, like most people say, everybody's using weed these days.
Yes.
When you say that colloquially, but compared to what people used to use cannabis versus alcohol, I feel like it's flipped completely.
It actually, I did read that recently, that there were more people using cannabis daily than there were drinking alcohol daily, and that's a major shift.
Yeah, and I don't know if it's better. I kind of hope so because that's the current state. So I just hope it's better. But
Yeah.
let's kind of get into some of that stuff.
Better in what way? You mean
Right.
safer?
Well, let's
or-
talk about risks.
Okay.
What are some of those widely documented risks or harms associated with cannabis use?
Well, there are 4 specific areas that we are pretty clear on that that can be affected by, especially daily or heavy use, and definitely by these high concentrate products. So the first one I would talk about is neurocognitive function or cognitive function. We know definitely that it affects memory, concentration, attention, processing speed, reaction time, all kinds of things that you wouldn't necessarily think about. We all-
Everything you want a teenager to
Yes, exactly.
not be affected
All of
by.
these frontal lobe functions that aren't there till, aren't set till you're 25 or 26. And that would be one of the caveats I would want to say is, I don't know that you can tell a teenager, don't smoke pot.
Sure.
I think you could try really hard as a parent, and I certainly, with my 3 teenagers, I tried really hard. Like, can you just delay it? Give
Yeah.
your brain time to mature and be fully functional before you start messing with it. Because adolescence is such a vulnerable time.
Yeah.
There's so much brain maturation that's occurring, and we know that cannabis disrupts it.
Would you say that in those circumstances, it's the big fear is the regular use?
Well, regular use and early onset use. So research is really clear. If you can at least, if you start at 13, there's a lot that happens. If you start at 15, there's a lot, but a little bit less. If you start at 18, it's a little bit better. So if you can delay the onset of use, that can be really important.
So the more my brain is mature, the less negative
The less-
impact I
right.
could potentially have with
Exactly.
cannabis use. That makes
Exactly.
sense.
Yeah, so just
that's
lock your
probably true
kids
for a
up.
lot of things like alcohol and
Oh,
everything else.
definitely. Yeah, definitely. When you look at a drug like alcohol has very clear neurotoxic effects. With cannabis, we know that when you're high, you're kind of dumb,
Yeah.
right? We all know that.
Right.
As it wears off, though, do you stay dumb or do you come back? And most of the research shows we come back, right? So it's hard
But that
to know
doesn't mean it's
over
not
time.
having.
It doesn't mean it's not
you
having.
do that enough times, it could
Yes.
have a cumulative negative effect.
and
that's
everyone's different.
right. And it
right?
seems like because it can sneak by you, like, oh, well, it's not really affecting me, quote unquote.
Right.
And you do it again and again and again. And so the danger is the not recognizing
Right.
it after use.
Right.
Sticking around. It's-
Especially if your cognitive function is slowing, you're not going to, you don't know.
But how do the regular or high potency usage affect mental health, especially in those types of people that maybe experience things like trauma or other types of situations?
Well, there's a lot of ways that it can affect folks. I mean, one of the things that I hear most from patients that I see is that this is the only thing that takes the anxiety away. This is the only thing that, I'm hyper vigilant all the time. I have nightmares. I have intrusive thoughts. And this is the only thing that kind of calms that down. So what the research shows us is, yes, that may be true while you're intoxicated, but over time, chronic use only worsens the anxiety. And most of my patients will tell me after a year or two, like, oh my gosh, you were right. I realized I was getting so much more anxious. It's only when I stopped that I realized that. And part of that is because you go into withdrawal. So in between using it, you go into cannabis withdrawal, which is characterized by sweating, irritability, moodiness, sleep problems, appetite problems, craving, and that can start an anxiety loop because then you have to keep using. The same way withdrawal does with most drugs. There's a reason people keep using it is because they start to feel uncomfortable when they're not using it. So that's one of the issues with that. The other issue is, you up your risk of developing a cannabis use disorder. A cannabis use disorder can be pretty awful. That's when you continue using despite the fact that you've had social consequences, health consequences, interpersonal consequences. You're typically developing a tolerance to the cannabis, so you're having to increase how often you use or the potency of the products that you use. And you can also have withdrawal symptoms, and withdrawal syndrome is real. We didn't recognize it until the last DSM came out, so it's, but there had been research for a decade. Before that, we do have a withdrawal syndrome. And so people always say, oh, you can get psychologically dependent, but you don't get physically dependent on cannabis.
I've heard that a lot.
Yeah, that's not true. There is definitely a physical dependence that comes along with it, and that's shown through tolerance and withdrawal.
And I'm guessing the longer and more frequent you use, the harder those withdrawals. So if you just smoke, let's say once in a while, whatever, these human beings out there that are use cannabis recreationally, not on the daily, are probably not going to feel those.
Probably not.
Maybe groggy, whatever it is.
I mean,
but you're not going to have these. Like what you're talking to is the regular use becomes dangerous because now we're depending on a product to just get through the day.
To get through the day, right. So my yardstick is always off when a parent comes in and says, my kid, I think he's smoking like every Friday. And I'm kind of like, I work with people who smoke 6 blunts a day. So, every Friday doesn't sound bad. But then I have to remember, okay,
it's still
this is my kid. I don't want this happening. And one of the issues is high potency concentrates are fairly new. We don't have a ton of long-term studies. So we don't, think about how long we've been trying to demonstrate that cannabis is harmful to the brain. We've been doing that for 30 odd years at least, trying to demonstrate that. And so with the high potency concentrates, at least anecdotally, it looks like if you use those products, you're going to have a more serious withdrawal, a more severe withdrawal, and you're going to have a harder time quitting. And you're going to probably develop cannabis use disorder a little more quickly, and it may be a little bit more severe. But I think that sort of makes sense. Right?
Totally. It's like going from light beer to shots.
Exactly. It's a dose-dependent sort of idea.
Yeah. The higher the amount of dose I'm going to have, the more dependent I become on it.
Right. Yeah. Exactly.
Like anything else.
Exactly. And then there's also, more long-term effects might be respiratory or cardiovascular. I always know a kid who's vaping when they come into my office because the cough is just ridiculous. Like it's coughing fits and phlegm. And I say, you need to put the oil pen down. Like, what are you talking about? I have a cold. Like, really, every single week for the last 6 months, you've had a cold when I see you.
Clearing of the throat constantly.
Exactly.
Yeah.
So you could always tell. So the cardiovascular issues, people may not be aware of this. The most consistent side effect of cannabis when you smoke it is a rapid increase in heart rate. Your heart rate jumps up 30 to 60 beats per minute. I think with older adults, that's what can cause that sort of anxiety or paranoia feeling that a lot of older adults will report when they first start smoking. Yeah. Because I think they're paying attention to that heart rate. When you're a teenager, you're not paying attention.
They're
to your
alone.
Heart rate.
It's quiet.
Yeah, and suddenly they're
aware
like,
of it.
Yeah. Whereas teenagers aren't really thinking about that kind of thing. So, but there's definitely respiratory and cardiovascular risk. There's been some work looking at whether there's a link to lung cancer, because if you smoke joints, the combustible stuff is very similar to smoking a cigarette, a tobacco cigarette.
It's still burning plant
Still
matter.
Burning stuff, absolutely. And there's a whole bunch of other stuff that comes in there in addition to the plant material. So the link between lung cancer and cannabis smoking is not a strong one. They've not been able to really show that, but that's certainly something that's being looked at.
It lends itself to the potential of it just for the mechanism. It certainly
Absolutely.
does.
Absolutely.
Now, is there any connection between cannabis use and serious outcomes such as psychosis or emotional dysregulation? Because we hear these stories of like people basically becoming schizophrenic after using too much weed, essentially.
Right. I mean, this is an area, we could have a whole podcast on this because it's a really controversial field. I would say the short answer is yes, there is a link. However, there are caveats to it. I think the link is going to look stronger now because we have these high potency concentrates, because I think that's going to be what really kicks people up. I would also say I would believe that most people who develop a psychotic disorder after using these products had an underlying genetic predisposition. I don't think you're walking around fine, you smoke pot, and suddenly you become psychotic. There's certainly psychotic-like symptoms that you have while you're high, right? Some mild hallucinations and perceptual disturbances. People can get very paranoid on cannabis. Those are psychotic, classic psychotic symptoms. They can have delusions where they think things are happening. So there is certainly that psychotic-like experience that can come with especially high-potency products. In terms of developing the psychotic disorder, not everyone who smokes pot is going to develop a psychotic disorder, obviously. For those who do, I have seen enough people in my practice that have been smoking these high-potency concentrates and suddenly have a bipolar sort of issue that they didn't have before. They may have had it anyway without the cannabis, or it may have come out under some extreme stress, or it could have come out after they did a bump of cocaine, or it could have come out after alcohol, like something there's some perturbation in the brain that brought that out. So I do believe there's a link. I don't think it's a super clear
So you're saying the link might be an underlying genetic issue that these substances might bring to the surface under certain circumstances.
Exactly.
So it's not the cause of psychosis rather than a tool used to reveal it almost.
I think it could be. And some of the latest research shows that what it could do is bring on that first episode psychosis 2 to 6 years earlier, which is significant, right? If you think about the typical psychotic period, we think about the vulnerable period as being mid-20s to late 20s. If it's coming on at 18, the prognosis for that is likely going to be a lot worse, right? Because it's coming on so early. And so some of the studies have shown that there's an earlier onset of that first episode.
So it's almost like breaks down your resilience to something that's already inside of you.
Yeah, it could be. Yeah, absolutely.
Because if you had good, healthy mechanisms, it probably would have never
Maybe it wouldn't have come
itself.
out. Exactly, exactly. And there's really no way to know that because we can't really do those studies.
Okay, well, let's get into that. Let's
Okay.
get into conditions and studies, things we know, essentially. We'll transition here.
Okay.
So what conditions or symptoms has cannabis shown potential to treat based on the actual evidence?
The actual scientific evidence.
Yeah, what do we know, essentially?
Okay. We know a little bit. We don't know a lot. There are at least 4 indications that have pretty strong data to support the use of cannabis for treating them. One of those is chronic pain, especially neuropathic pain or nerve-related pain. There have been some meta-analysis studies that have shown that there's some improvement in pain. It's often modest, but I would say if you are suffering chronic pain, even a modest improvement is going to make a huge difference. So there's definitely that. And then there are some patients that use cannabis to try to replace their opioid medications, to reduce their reliance on opioid medications. And I think there's some mixed evidence for that as well, that can be helpful. The second one would be chemotherapy-induced nausea, and that's probably the earliest clinical use that we know about.
That's the one we think about classically is when marijuana was becoming legal. The oils and the use of edible oils. I believe one's called like Rick Simpson oil, which was like
Yes.
invented basically for that,
Right,
which is
right.
like 1,000 milligrams of THC. Here, take this because you're dying and we need to get some food in you.
No, absolutely. Yeah, for AIDS wasting, but definitely the chemotherapy nausea. And those are more from the synthetic THC, so like oral THC, which I'm sure folks know about, dronabinol. It's called Marinol.
Yeah, I remember that.
Yeah, or Nabilone. And those are actually FDA approved for that indication. You can actually get that medication prescribed for chemotherapy-induced nausea. The other one would be spasticity and multiple sclerosis. And there's a medication called Sativex or nabiximols, and this is a 1-to-1 THC to CBD ratio, and it's an oral mucosal spray like a asthma inhaler almost. It is not FDA approved in the United States though, but it is in Australia and some other countries, and it's a pretty effective antispasmodic medication. And
When you say spasm, like seizures or physical,
more
like Parkinson type
like,
spasms?
Yeah, like multiple sclerosis,
Okay.
those kinds of things.
Yeah, the uncontrolled nerve stuff going on.
Exactly.
That's the second time you talked about nerves in the use of cannabis. I wonder if there's a relation between the nervous system.
Oh, for sure. Yeah, definitely. It does. Yeah, for sure. And then finally, there are rare pediatric epilepsies. And then there's a drug called Epidiolex, and that is an oral solution and this is cannabidiol or CBD alone. There's no THC in it. And that's actually a very effective anti-seizure medication, and that's FDA approved for these rare pediatric epilepsies. So those are the 4 areas where we have really compelling evidence that...
But those aren't people using stuff you buy at the weed store, right? You're talking about
This
distilled in a
is
very
distilled
specific
and
formulation.
These are what I would call pharmaceuticals and not...
This is lab-done
different.
stuff
Yes.
that is specific use. Okay, so
Right.
it's not like we were saying the medicinal effects of what you go buy at the dispensary.
Right.
It's not the same stuff. So we're talking about the effects and the uses of it in a therapeutic way.
This is a very cleaned up way of taking THC or CBD. But it is THC and CBD, although you're right, it's typically synthetic.
So is that because we haven't studied it appropriately, or like what?
Well, there's a few reasons, and I can get to that in a second.
Yeah,
I guess the other areas where we have done some research, although the evidence is not clear, one of those is going to be anxiety and depression. And so part of that I had alluded to earlier, that we know that you might feel better in the moment, but over time, it looks like depression and anxiety will actually get worse if you use chronically or you use high-potency preparations. And then the next one would be PTSD, and I know that would be of interest to a lot of people. A lot of folks take cannabis for the intrusive memories, the nightmares, the hyperarousal, anxiety, not wanting to leave your house, not wanting to be able to interact with people. And that, there's very mixed evidence for that, only because we're not able to do these studies. There's only been one published study looking at veterans with THC, and what they found was that it wasn't any better than placebo. So there was really no signal, so to speak, that it would be helpful for PTSD.
So the federal law kind of limits the ability for anybody to really dive into these studies.
It's more difficult than it needs to be. So 20 years ago, when I wanted to study, are there ways that we can treat people with cannabis use disorder? Can I test a medication that might interfere with craving? Can I test a medication that might interfere with how high you get? So maybe you won't want to get high anymore. That's not hard to get through. So when we talk about regulatory, we're talking about FDA, and we're talking about DEA, and we're talking about NIH. So you have to have these three align to get a study like that through. But in a laboratory setting where you're only giving it a few times, that was not that hard to do. Now what I've sort of switched over to is this idea, are there therapeutic benefits to using cannabis? And we need studies like that because we don't know. There are no well-controlled randomized clinical trials. That's sort of the gold standard of how the FDA will decide, is this a beneficial drug? Is this helping people? Is there a cost benefit, or not cost, but a harm and benefit balance that's good? So then when we started when we started thinking, okay, we're a lab that can do this. We have all the regulatory permissions to administer cannabis to people, right? Not many labs do. It took us a while to get there. Those would be studies that you want to do, but suddenly, not suddenly, FDA is a little more reticent to let that kind of a study go, because now we have people smoking lots of cannabis and trying to track PTSD and suicidal behavior, and those are very risky studies.
That's hard to get that toothpaste back in the tube.
It's hard to, yes, definitely.
So I certainly understand the apprehension from a big political level. I mean, you don't...
And safety,
There's
absolutely.
a lot of people here. We don't want to just unleash the Kraken here,
right?
Or Pandora's box, or whatever analogy you want to use.
Right.
But it does seem like, from what I'm hearing from you, is there are very specific things we have found that there are benefits. Mm-hmm. There are things that people say that anxiety and depression, it really helps me. It helps me. And it feels like you're saying is people are using it more of a crutch for a short-term relief and a long-term problem.
Mm-hmm. It can be.
And we don't know the effects of many things right now based on the fact that we can't study it to the degree of which we ideally could to get all the answers in that realm.
Right.
But based on all that, what leads trauma-exposed or high-stress professions like first responders and military veterans to turn to cannabis?
Well,
based on what you know, because again, we don't know.
No, we don't
on what
know.
You think.
So these sort of vulnerable populations, I think these are really high stress jobs. There's a lot of, there's shift work, so there's sleep disturbance, there's secondary trauma just from witnessing trauma and helping people, seeing people who've been traumatized. These can lead to intrusive thoughts and nightmares and re-experiencing things, those classic PTSD kinds of symptoms. For firefighters, for example, there's a lot of musculoskeletal pain, right? There's wear and tear, same with cops. It's a very physically demanding jobs. And so there's a lot of stress. There's just a ton of emotional stress and anxiety from those jobs. So I think that's one thing that would certainly lead towards this as an alternative medication. A lot of them don't want to take opioids or benzodiazepines, right? They have high abuse liability, meaning that people get addicted to them fairly easily.
And people are starting to drink less.
Right, exactly.
So it's almost like if that's happening more in those populations, it's maybe a coping mechanism for the physical and mental effects of their job.
Definitely.
Well, we're leaning on something, right? And there's a danger to leaning on something because that thing could break and you could fall.
Well, it's a slippery slope, I think. And then I think the other thing is that, there's a stigma to seeking mental health help, unfortunately. I may be overgeneralizing, but I think in some of these high-pressure jobs, you're not supposed to need mental health support. Right? You're supposed to be able to just do this job. And so where do we leave people? So then they can't talk about needing help, or they don't know where to go for help, or so then they start smoking pot might seem like a less stigmatized type of care than saying, hey, I'm going to go see a psychiatrist.
Totally.
Right? And that's horrible. But I think that's probably
some people's friends probably tell them you just need to smoke a joint and hang out with me and you'll
just
feel
calm
better.
down. Yeah, exactly.
Right?
And I think that, the other thing is cannabis works fast. It's reliable. It works every single time. It works quickly. You come see me for therapy, it could take 2 months before you have real relief, right? I can teach you skills to have momentary relief, but it doesn't work as fast. You're only going to see me once a week, right? So if you think about that, there might be an attractive thing about smoking pot instead. I can really see that. But I think what's worrisome is that it is still federally illegal. And so for a lot of folks, there's a trade-off. Am I going to take care of my personal mental health, or am I going to risk my career? Right. So for firefighters, obviously that's going to be an issue. For police, that there's federal firearms. If you test positive on a drug test, you can't carry a weapon. Right. Isn't that correct?
I'm not a police officer.
Yeah, I'm not either, but I'm assuming.
I'm assuming there are a lot of rules. I know where
regulations.
I work, and I'm assuming this is true for dang near every fire department in the world, is that the use of marijuana is strictly prohibited.
It's a zero tolerance.
Yeah,
Absolutely.
right. Now, there is no rule that you can't drink off duty, but there's no law that says it's prohibited. And there's this like back and forth, but it's illegal, it's this, it's that. It's like, but your employer still has the right.
Right.
To limit the use of these things, if not say you can't use them. And I think that's a big one here. Are there people still using? Yeah.
Oh, yeah,
There's
of course.
people doing
Absolutely.
cocaine.
Yeah.
You know what I mean?
Absolutely.
So the lack of legal pathways does not mean people aren't doing it. But I like what we're talking about is, well, here's what's actually going on.
And I think part of the problem is that where are they getting information? So one of the things I do at Wayne State is, I teach residents, I work with residents, and I think part of what physicians need to learn about is how to have a conversation with a patient who says, I think I want to try cannabis. None of this other stuff you're giving me is working. And then, you want your doctor to be able to say, okay, I think oral might be better. I think you should try 5 milligrams, maybe 10, but there are no prescribing guidelines.
There's no textbook that's going to lead you to that.
We have no data.
Yeah.
We have no data.
Right.
So am I going to say, is vaping safer than smoking? Everyone says it is. The data aren't really clear yet. I don't know.
What are you vaping?
Yeah, what are you vaping? And you don't know what you're getting. And so
Right.
now you're going out to somewhere and you don't know what you're actually getting, and now you're trying it. And so I think there's a lot of potential for gaps in care. And I think that's also true for veterans, right? Because the VA, they just recently started letting the doctors talk about it. They can't prescribe it, they can't give it,
But now they can answer
but at least
questions.
they can answer questions about it if they are trained to answer questions about it.
Which is fair.
So, absolutely.
Because it's not like like you said, they weren't getting it classically in their
No,
training.
they're
so
not.
You almost need
Nope.
to be certified to talk about it at this
Right.
point.
I think so too. We do very little education about addiction anyway, right, in a lot of our curricula. And then the stuff that we do talk about is managing withdrawal, how to get them to stop using. We're not talking about, okay, here are some indications where it might make sense for them to try it. And if they want to try it, here's how to do it safely. And that's the kind of conversation that people need to have with their treaters.
For those of us in the first responder community that are seeking relief, I think some people certainly have leaned on things they shouldn't, whether it's alcohol, drugs, or less drugs.
Impulsive behavior, there's
Sure,
all kinds of
all
stuff.
sorts of
Yeah.
things. What advice would you give to someone who's in those scenarios? What should they be considerate of? And what other options are out there for those people to alleviate what they're trying to get rid of?
Let me start. You asked me several different questions there.
I did.
I guess I would say education is key. I think you need to know the risks. And unfortunately, what that might mean is doing your own research and really looking into what are some of the risks. And we went over some of them that are fairly clear. I think you need to have discussions with your physician that I want to do this, because here's the other thing. There are drug-drug interactions. And these folks that are 65 and above that are starting to smoke pot are on a boatload of medications.
Yeah.
And what if something interacts with CBD that you didn't know about and suddenly something terrible happens? So you have to be able to talk to your provider about it. And so I wish providers would be more up to speed on some of it. And even if you don't support it or you don't love the idea, at least be knowledgeable so that you can have a conversation with your patients about whether this is a good decision for you. So that would be one thing. I would also say be open if you have a therapist. If you come into me, like, I can tell if you're high, right? I know what high looks like.
You've been doing this long.
Yeah, I've been doing this long enough.
Yeah.
And like I said, I was a wild child. Like I know when
Your
someone's
kids aren't
high.
getting away with
Oh, they
anything.
don't get away with anything. So I can tell. But you know what? I know if you're sitting here and you're high and I'm trying to do a verbal cognitive behavioral therapy, I'm going to have to repeat myself incessantly because you're not paying attention and you're not encoding what I'm saying. So, but if I know that in advance, or I can tell, I'm going to alter what I'm doing in that session, right? So you need to tell people things like that. I think you need to be aware of the risks. There's a rule in pharmacology called start low, go slow. Don't take 20 milligrams. Don't chug a big thing. If this is your first time, take half a gummy. Just see what happens. Don't do it and go drive. Don't do it and walk around in a dangerous
Right.
neighborhood. Be safe, right?
Yeah.
Be smart. So things like that, I think people could tell. I think knowing the risks is the big thing. If you have a family history of psychosis, know that. If you have a family history of addiction, know that.
If you already have psychosis or behavioral health issues.
Absolutely. It's going to exacerbate it, right?
Yeah.
It's going to make treatment different. It might bring the symptoms on more severely. There are lots of things that can happen.
And most of all, if your workplace prohibits it, that's probably your biggest concern.
I think so too. And I think what's difficult, especially for people in these safety-sensitive professions, is that there's almost a trade-off between taking care of your mental health and keeping your job.
Yeah. Yes.
Right, which is just ridiculous. I mean, people are in such a bind over it, and it's just such a disservice, I think.
It goes back to the openness with those around you. being able to say I'm hurting or
Right.
going through this might lead you to the actual care that you need rather than you trying to mask it, or at least you think you're treating it with any type of chemical.
Yeah,
Or
I think
impulsive
that's
action.
Yeah, that's an excellent point, because what happens is that you are actually delaying getting into an evidence-based treatment because you're trying very hard to keep this under wraps or keep it under control or contain the symptoms. And actually, you might be making the symptoms worse, right? There's a lot of research that shows people with PTSD can actually get worse on cannabis. Same with depression and anxiety. So we don't know enough about who it helps, how it helps, and are there some people that are more likely to get harmed by it? And that's the kind of research we really need.
It's almost like hearing you anecdotally say that all the people that think they need it actually would be harmed more by it over the long haul.
Some could be.
Because like
and
if you're
some
taking
people-
it for any type of I'm feeling in a negative way, it's a short-term game of I'm not thinking about it to a long-term problem of now I'm going to loop into those same feelings. They're going to be harder when
it's going to be harder. And then when I go into treatment, it may not be as successful.
Right.
And I think some of that is, if you look at sleep is probably the number one problem, or the number one reason that folks well, probably pain is, but sleep is up there. And what we know is it may help you fall asleep, right? But you don't always get REM sleep. You don't always get restorative sleep. So it may seem like it's helping, but it really isn't on a deeper level, if that makes sense.
It absolutely makes sense. So it's like if you wore an Aura Ring or any of those measuring devices, you'd be able to see if your recovery was impacted.
Yeah.
Because I know some people say, and I can't wear a watch. I hate it. I can't wear anything. But I hear what people say they have just a couple cocktails. They're wrecked.
Oh, alcohol's notorious for that. Like
Yeah.
you'll pass out, fall asleep, but then you will have restless sleep. It won't be restorative, right? You won't
Your
feel like
body's
you
almost
slept.
repairing itself, all the damage you did, rather than trying to healthy itself to just get back to a homeostasis.
Yeah.
So one person we had in here before was a firefighter
Okay.
who ended up going to inpatient treatment for marijuana addiction.
Okay.
And him saying like just basically trying to deal with his overwhelming feelings is what led him to keep using it, and then it led to hyperemesis disorder.
Okay.
Tell us a little bit about that. Give us a little more insight from your perspective. I know it's pretty rare.
You know what it used to be, and I actually have an ER doc friend who calls it scromiting.
Wow.
Which is someone who presents in the ER screaming and vomiting.
Wow,
So it's
yeah.
vomiting. Yeah. So it happens enough that they have a term for it.
No, yeah,
So,
I've treated this person. Yes.
Oh, okay.
Yeah.
So it is true. Yeah, I haven't seen it myself. I've only heard tell.
We had a patient back in his mid-teenage years,
Okay.
and then they moved out of the township, and then he recently moved back in. I know that because I saw him the other day and
Okay.
treated him, and now he's 30. And he was still having these same issues, and it
Really?
was very emotional vomiting.
Yeah. Okay. So it is scromiting.
Yeah.
Yeah, and really the only treatment we have is a hot shower. And I know some ER docs are using capsaicin, which is sort of a red pepper, and if you rub it on your stomach, apparently that can help. I mean, it's really strange.
Yeah, it is very strange.
Yeah, but it is not as uncommon as it used to be. I think you see presentations of it more
And that's
often.
just from that person's genetics
It's
being
overuse
overwhelmed with
of-
overuse?
Yep, it's overuse for sure.
Yeah.
And it's really heavy
Almost like an
use.
autoimmune disease.
It could be. I mean, it's your body's response to,
Like,
I mean,
stop it.
vomiting's usually trying to get rid of a toxin, right? So if I mean, that's very oversimplified, but that's
But
sort
it's
of how
almost
I
like
view
the gluten
it, right?
intolerance, almost like,
Yeah.
quit eating this.
Yeah, right.
Okay,
Yep.
I just wanted to bring that up.
Yeah.
So final question.
Sure.
What do you hope future research in this area will reveal?
I hope it gives us well-controlled, randomized clinical trial data that show, is it effective? And if it's effective, for whom is it effective? For what conditions is it effective? What are the lowest doses that we can take that are effective in the safest possible route of administration? So really you take the medication and you get the benefit, and hopefully you don't have, or you lower your risk of developing a cannabis use disorder, of having a neurocognitive issue later on, of having a cardiovascular response to it, or a respiratory infection. So, is it efficacious? Does it work? Does it help? Does it improve something? And is that a consistent improvement that we see in lots of people? And does it maintain over time? Is it only going to be a couple days that you feel better, but then a week later you're right back in the throes of it? That's not going to be a very effective medication, right?
So a full spectrum look at
Full
what works,
spectrum
how does it
look,
work, who does it help?
work for, what does it work for, and what are the formulations? Do you want a 1-to-1 THC to CBD ratio? Do you want a high CBD, low THC ratio? There's a lot of stuff we just don't know, and Another thing about these high potency concentrates, I'm not allowed to study them. I can give cannabis. I could walk down the street and buy any kind of oil cartridge I want. I can't give it to anybody, right? So we can't even study.
You're in the city of Detroit. In fact, there's many of them, and none of them are medical.
Right, and we're not allowed to give them. So we can't even study those. And then, there's also going to be, there's always genetic variation. Some people are going to respond to things. We all know that guy that was like, oh, I've smoked 5 joints and I didn't feel a thing. Okay, maybe. It's, it seems unlikely, but you know what? There are genetic variations, and some people, just like with alcohol, some people can tolerate, some people can't. And so, I think we need to know subgroups. I think we need to know, are there are there sex differences? Are there genetic differences? Are there, certainly there's going to be age differences. We know that there's menstrual cycle differences in how people respond to drugs. So I think we need to know all that kind of stuff. And there may be subgroup differences, like if you have an existing mental illness, or you have mental struggles, or, you have any kind of predisposition to something. All of those things, not everyone's going to respond the same way. And so that's kind of what I would hope, is that we get a better picture of the efficacy, but then also balance it with the risks. Like, we know it's going to harm some people. If we can predict beforehand who it may be harmful for, that would be really good information.
I totally agree. And I think all of this is really good information to kind of chew on. Thank you very much for your time.
Okay, sounds great. It was a pleasure to be here.
Thank you.
Thank you.
Thank you for listening to the Minds on the Frontline podcast. We have more great content coming out soon. Please check us out on YouTube, Instagram, Facebook, X, and LinkedIn. And make sure to like and subscribe to all Minds on the Frontline podcast social media channels. Thank you, and have a great day.